Thank you, Tamam. Thank you, Professor Tinica, and all the people here in this room. I'm very glad to be here and she's now to attend this meeting, this important meeting. And I'm very glad to talk about a very, very important problem in congenital heart disease patient, management of pulmonary hypertension. Well, first of all, we have to understand how our patients, congenital heart patients, develop pulmonary hypertension. There are two main topics. First of all, increased pulmonary blood flow, and then pulmonary venous obstruction in those patients. They born with some pathologies that can develop this. Other things to understand is the effects of cardiopulmonary bypass. All these are worsened or triggered by some conditions such as hypoxia, that is normal in univentricular heart, hypercapnia, acidosis and pain, and so on. Well, talking about the pathophysiological condition, we know that many pathologies suffer for pulmonary hypertension during the life and after surgery. And we can make this in complete AV canal, VSD, especially those patients that are in natural history and are not treated when they are infant, for example. Truncus arteriosus, total anomalous, and partial anomalous venous connection, chortria triatum, aortopulmonary window, and congenital metal stenosis. Other pathologies can suffer for pulmonary hypertension, but in less present. Well, there are other consideration about the surgical procedure, because these pathologies are associated with surgical procedures, and surgical procedures can affect negatively the pulmonary pressure of the patient. Sometimes just the surgical procedure can solve the pulmonary hypertension of the patient. And we know that many different approaches to the previously listed pathologies may require selective pulmonary vasodilation after repair, just in the OR. We know also that there is a list of almost 20 surgical procedures according to the Aristotle score. That is a score in which preoperatively and according to the surgical procedure can address the risk of morbidity and mortality in these patients. And we know that many of these patients can have a benefit from selective treatment of pulmonary vasodilation. And are those patients who reaches 8.5 of Aristotle score. But keep in mind that the concept of usefulness of pulmonary vasodilation may be not necessarily associated to a preoperative risk profile for pulmonary hypertension. Sometimes we operate VSD, for example, and older patient with VSD, and it's not necessary to use any kind of vasodilators because we solve the problem just closing the VSD. Sometimes we have to use other types of assistance, such as the mechanical assistance device, ECMO, and ventricular assistance device. And talking about the effects of cardiopulmonary bypass, we know very well from a long time, this is an old paper from UCLA, School of Medicine, that there is cardiopulmonary bypass affects negatively the pulmonary vascular resistance. In fact, in this paper, they studied 12 piglets. 6 of them received preoperatively mercaptopropionil glycine and catalase that release the cells, release the muscle. And they noticed that there is a reduction in pulmonary vascular resistance in those piglets treated respect the other piglets that are not treated. And this is one of the most important papers really, that address negatively affect to pulmonary hypertension regarding cardiopulmonary bypass. Obviously, all these conditions are worsened by other normal conditions that we have in intensive care in the post-op period. There are some precipitating events such as cold, suctioning, acidosis, and so on that can maintain and sustain pulmonary hypertension and can worsen pulmonary hypertension. So we have to broken this circle, this vicious circle, just to keep the patient in a very good condition to be treated as soon as possible and to permit the rapid extubation of the patient. We have to keep in, we have to treat the patients with some different ventilator strategies. We know very well the ventilation strategies. We have to oxygenate very well the patient despite the patient has a single ventricle morphology, treat atelectasis, use PEEP, and so on. You can alkalinize the patient, you can ventilate the patient, putting the patient in a mild respiratory alkalosis, use nitric oxide, and we will discuss of nitric oxide after. You have to control any stress response of the patient, control the pain using, for example, opioids. I prefer to use morphine. In my opinion, morphine, and in our opinion, morphine is one of the best choice for controlling the pain of the patient and to sedate also the patient. Use also some sedatives in a junction of morphine. I use normally midazolam, and also, if it's necessary, use muscle relaxant, and you have a lot of muscle relaxant to choice. We use normally cisatracurium because the cisatracurium has no histamine release, and is one of the best choice in this case. In older baby, we use propofol to maintain sedation. But how common is severe pulmonary hypertension after cardiac surgery in this subset of patients of congenital heart disease? Severe pulmonary hypertension is not so frequent. It's a rare event, but this rare event is associated with a very increased morbidity and mortality. And in this Swedish paper, they studied all the patients that suffered from pulmonary hypertension and found that the population who suffer for this is more or less 2% of the cardiac congenital heart disease. We are talking about the severe pulmonary hypertension, that pulmonary hypertension that needs absolutely to be treated and that can put at risk of mortality the patient. They divided, according to the Swedish National Health Institute, the patient treated into different groups, and they found more or less what we heard before, that the worst group is the 3C, that is the preoperative group of high-risk patients for developing pulmonary hypertension. And in effect, in this group, they had more or less 50% of mortality. 4 patients to 9 patients died. And 2 of these 4 patients died in the operating room directly. They were not able to discharge from the cardiopulmonary bypass. This is our experience in last year, in 2012. We performed 433 congenital heart disease cases. Congenital heart disease because we treat newborn, infant, and other congenital patients. No cardiac transplantation, and we treated for severe pulmonary hypertension, 11 patients with nitric oxide, for example, and more or less 2.5% of the population. So we are in agreement with a previous paper I showed. This is our population. And these are the two main conditions that needs some kind of vasodilation in the immediate postoperative care to wean the patient from the cardiopulmonary bypass and to treat the patient in the intensive care, truncus arteriosus and total anomalous pulmonary venous return. 4 of 5 patients were treated with nitric oxide, and 2 of 3 patients were treated in the total anomalous pulmonary venous return, were treated with nitric oxide in the post-op. Well, nitric oxide is a very, very useful drug. We have a lot of experience in this, as Marco Diena and Dr. Tarmam Youssef said before. And there is a great consensus in Europe in using this, especially because nitric oxide is effective, and there are numerous reports of using inhaled nitric oxide in those kind of patients. Not only for treatment of the cardiac surgical patient in the post-op, but also using it as diagnostic tool in the cath lab for some kind of pathologies. And again, the main convincement is that nitric oxide gives what we give to the patient with inhalatory nitric oxide is what the patient is not able to produce endogenously, because this kind of pathologies belongs to this kind of problem belongs to the original pathology. These patients, especially those patients who suffer for prolonged overflow in the lung circulation, the right circulation, suffer for decreasing of endogenous production of nitric oxide. So when we release this, we have an immediate response in terms of reduction of pulmonary hypertension and improving hemodynamic profile of the patient. And this group of experts recommend also the routinely use of nitric oxide in all the children at risk for developing pulmonary hypertension in the post-op. So they exhort us to use it, and also they talk about the dosage of nitric oxide between 20 to 40 parts per million of inhaled nitric oxide. That is what we have done in 10-15 years to our patients, and so we are in agreement with the literature and with all the expertise. So how to proceed to use nitric oxide in this kind of population? First of all, we have to identify all patients at risk for developing pulmonary hypertension in the post-op. And we have to identify those patients on the basis of the physiopathology of the congenital heart disease. Define also the procedures that do not require pulmonary vasodilating. Consider the diagnostic use in cath lab of the nitric oxide. And you have to define correctly the need for pulmonary artery pressure measurement, and also to define all the procedure that needs strictly control of the pulmonary resistance, such as, for example, Fontan procedures that benefits from reduction in pulmonary vascular resistance just after the correction. Consider also different uses of nitric oxide. For example, when you have a patient with the left ventricle assist device or patient on ECMO. using heart transplantation, but we don't have an experience because we don't do heart transplantation, define the winning strategies. We use always sildenafil to wean the patient from nitric oxide. And in the last 5 years, I noticed that the rebound phenomenon of stopping nitric oxide is very, very low, is decreased using sildenafil. Consider also the setting of good patients, and you can use, we can consider off-label, for example, nitric oxide in the restricted physiology and right ventricle dysfunction, for example, in the tetralogy of Fallot. That is quite a nonsense, but sometimes we had to use with good results, helping the right ventricle. Well, the great majority of the patients undergoing cardiac surgery may easily sustain the cardiopulmonary-derived increased pulmonary vascular resistance. However, under certain circumstances, this increase may induce a difficult or impossible weaning from cardiopulmonary bypass. So we have to use some other strategies, such as we have to use nitric oxide or put the patient on assistance device. But we know this before, usually. We know because many conditions leads to the risk of this. The use of nitric oxide in treatment the patient under assistance device is well known, and especially when you have a patient with a left ventricle assistance device is useful, because the prerequisite of left ventricle assist device insertion is that the right ventricle is correctly working. And right ventricle dysfunction, refractory to conventional therapy, occurs normally in 20 to 40% of the patients supported with left ventricle assist device. And this condition may benefit from inhaled nitric oxide, for example. We know that nitric oxide, that right ventricle suffer, or better, is dependent of venous return, as is dependent of the good afterload. So if we reduce the afterload and we have a good venous return that normally is increased when you are under left ventricle assist device, your right ventricle tends to work better. And in effect, nitric oxide is used to decrease pulmonary vascular resistance and then to increase the filling of left ventricle assist device. So always consider this in those kind of patients. Going back to the pediatric population, we use ECMO for this population, for the pediatric patients. Is more completed and can assist the patient with heart and lung better than the single ventricle assistance device. And this is opposite to the adult patient that may benefit for single assistance device than ECMO. And in effect, when we have a patient, children patient that suffer for severe hypoxia, pulmonary hypertension, and right ventricle failure, we put this patient under ECMO. And this is in accordance also with the ELSO registry, International Register of Extracorporeal Life Support, in which almost 15% of the population, children population, pediatric population, is assisted by ECMO in cardiac surgery, with a survival of 40% more or less. And in our experience in the last 3 years, between 2010 and last year, 2012, our survival rate reached more or less 60% in total the pediatric population. And 60% means that these 60% of patients are at home, discharged at home, not survival only. This is a very good result for us. Well, our strategy, we normally stop and reduce lower dosage of catecholamine under ECMO, and we start as soon as possible levosimendan, better than mirinon in this case, because levosimendan acts as inotropic drug and reduce pulmonary vascular resistance. To treat right ventricle dysfunction itself and vasodilatory shock, we use vasopressin as a vasoconstrictor because vasopressin don't affect negatively the pulmonary vascular resistance. Vasopressin, that is a vasoconstrictor, release the pulmonary vascular smooth muscle, so there is a decrease in pulmonary vascular resistance. We use continued intravenous sildenafil that we have from January of last year, 2012, and we use inhaled nitric oxide just before ECMO weaning. So this is our strategy in course of ECMO for treating pulmonary hypertension patient. Levosimendan is a very good drug because applied to two conditions. One is the vasodilatory condition that, on the smooth muscle, and the other one is the inotropic performance. Well, this is supported by the literature, not only for the adult, the children, but also for the adult patients. And in this European expert recommendation also, there is our contribution as center with Marco Ranucci, in which we give the basis of treatment of adult patients with nitric oxide. But, well, we move to other treatment. We know from this morning that there are other treatment, specific drug therapy, such as, for example, calcium channel blockers. I don't talk no more about this. Prostanoids, the most uses is epoprostenol, but iloprost was used also by inhalation. Inhaled route is advantageous because it's selective for pulmonary circulation. Terprostenil, again, Beraprost, and other drugs that acts on the endothelin receptor antagonist, endothelin 1. They are antagonists of the endothelin ATA and ATB receptor. Bosentan is the most representative in this category and is very well used in, especially in the Gutsch patient, in adult congenital patients, before and after operation. Sometimes we treat for 6 months the patients, adult patients, congenital patients, with Bosentan prior to surgical operation. And then we come back to use Bosentan after the operation in those patients for other 6 months, and then we control the pulmonary pressure, and we try to titrate the administration to the condition of the patient after the surgery. Bosentan is used also in pediatric population, but the use is off-label till now, just only for study. But a lot of papers are coming using Bosentan. Sitaxetan and ambrisentan are the same, but the most used is Bosentan. We move on the phosphodiesterase 5 inhibitors, and the most representative is sildenafil. We use sildenafil in a lot of patients, congenital patients, newborn, infants and also adult patients. We use also, as I said before, intravenous sildenafil in those patients who are refractory, and so, in particular in those patients who are in ECMO, under ECMO, for treatment of pulmonary hypertension crisis. And then, when we have to wean the patient from nitric oxide, we start again orally sildenafil. And we discharge the patient at home with orally sildenafil. Tadalafil is another phosphodiesterase 5 inhibitor, but most used is sildenafil till now. Others are coming. There are other experimental compounds, including serotonin, tyrosine, and so on. They are in phase 2 and 3 of studies, and in an earlier stage of development, for example, Rho kinase, fasudil, is very promising molecule in treatment pulmonary hypertension, such as stem cell therapy and gene therapy. Most promising is the combination therapy. There are a lot of trials that talk about the combination therapy, especially bosentan and depoprostenol, BREATH2 and BREATH5. But this combination therapy until now is reserved only to a subset of patients, very, very specific patients. We know also that beside the pulmonary hypertension problem, we have to treat the other problems. First of all, the arrhythmias. In over the 2 years under atrial fibrillation, the mortality rise up to 80%, so we have to treat as soon as possible. Sometimes we treat arrhythmia also in the lab, in the cath lab, with some procedure, invasive procedure. One other treatment that is the treatment prior heart lung transplantation is the balloon atrial septostomy, when you have a refractory patient to the conventional therapy. But also here, the decision to put the patient under balloon septostomy is very, very hard, and you have to choose the patient. It's not simple for any patient. Some key points to conclude. Pulmonary hypertension is common in patients with congenital heart disease. Severe pulmonary hypertension is not frequent, but is a very dramatic event when you encounter this. Pulmonary hypertension in these patients can be caused by pulmonary arterial or pulmonary venous causes, and nitric oxide is the best choice, remains the best choice till now in acute care. So we have to use this as a first choice in this kind of patients. Then you have a lot of other drugs that you can use, but the combination therapy is the most promising therapy you can use, more than a single therapy, but needs more study for using this. We can prevent pulmonary hypertension through early identification and repair of congenital heart disease children, and this is the ideal patient management. The problem, we have some problem with patients that are not treated in infancy, that growing up with natural history, such as VSD, for example, and these patients are at high risk of developing pulmonary artery hypertension, Eisenmenger syndrome, and obviously death. Thank you.
Any question?
How do you prevent the pulmonary hypertension crisis and the rate of this complication here with Well, I prevent pulmonary hypertension just knowing who is the patient that can suffer for this, and if we have a patient known for developing pulmonary hypertension in the post-op, we can treat it. We can treat him with sildenafil or bosentan. sildenafil if the patient is an infant or children, bosentan if is a young adult. And we started also to treat some patients with some children with bosentan, but we have a few cases, only a few cases. And then you have to know which is your patient. We have to know if your patient is the patient that developed a pulmonary hypertension crisis. So this is the only thing that you have to do. In our experience, for example, last year, we lost just one patient for pulmonary hypertension crisis. The other patients were discharged, were weaned from nitric oxide. Some of them, I remember 3, died for prolonged ventilation, died for ARDS, so infection at the end. That is common in this kind of population. So we have to understand the patient. We have to know the patient very well. We have to prevent, but not always is simple to do this.
When you don't have, because not everywhere is until 2012, you hadn't sildenafil. How you treated usually before to have this? I mean, it's important to.
Intravenous prostacycline,
Yes.
for example. And now there are available a lot of drugs such as Mirinone.
Yes,
and
yes.
also sildenafil that can be used for to treat pulmonary hypertension. Prostacyclin was the most used intravenous drug for treatment.
What do you say about nitroprusiat? Somebody use it?
Somebody used nitroprusid, but is not selective.
Yes.
It's not selective. You can use also nitroglycerin, whatever you have to decrease resistance, but some drugs are not selective. This is the problem of the drugs. Also, Mirinone is not strictly selective for pulmonary hypertension crisis.
Because we must think about some centers which they don't have this kind of treatment, and we must find some solutions or something.
I know. We have a lot of experience abroad when we go on mission, for example, in Tunisia or in other parts of Africa, and we don't have nitric oxide, so we have to use what we have, and generally we bring with us Mirinone. Mirinone is the best choice.
Thank you very much.
Sorry? Well, depends on the urgent you have to operate this patient. It's not clear if sildenafil before operation helps you to reduce the pulmonary vascular resistance. Normally, what we do is to put the patient in the OR, and then we treat the patient surgically, and then we treat the patient for pulmonary hypertension crisis. We have few patients in which we treated with sildenafil before, trying to reduce the pulmonary hypertension, and seems to be active. And this was done for 3 months before the operation, 2-3 months before the operation. But we're stable patient in which the surgical can be postponed. And so we started to treat this patient, and then we treated, but we don't know if the pretreatment is useful or not. We tried. It's just like evidence-based medicine, non-supported by the literature.
In your experience, which age, until which age this congenital heart defects which shunt, left to right shunt, you can also to treat it in Italy or abroad, in your experience?
We can treat or we have to?
We have to treat. I mean your experience, which age, the maximum age which you have done in your experience about that?
In January in Kurdistan, in March, last March, in Kurdistan, we treated a 14 years old boy with a large VSD. And we didn't have anything. The problem was, let him die, or we tried to treat him. The patient was good. Was extubated 3 hours after the operation. I don't know why.
Complete surgical correction, of course, because we have a lot of these patients and we have no explanation about that. Usually after 2 years you can't operate them, but you find a lot of patients by 10 or 12 or 9, 5 years, which you close the VSD and you have a very good results.
In January...
Or some truncus sometimes.
Yes, also. In January, we operated a young female, 21 years old, of tetralogy of Fallot in natural history, and Dr. Fegiola did complete correction. This young girl arrived in squatting, completely squatting, and she's alive. And in March, we saw her. So.
Thank you very much.
I don't know why, but it's
Thank you
possible.
very much for very nice